Thank you so much. Thank you so much for that warm welcome. And I just love being with all of you here today, full of life, so inspiring. It just brings back the importance of what we all do as a partnership together, right? Everything we do in lung cancer research is for our patients. And this is not a journey that they go through alone. Their caregivers are equally participating in that journey with them. And it is incredibly humbling to be a small part of that journey in terms of helping to advance the science related to lung cancer treatments. So when Lynn had spoken with me earlier, she had asked me about a presentation I was going to be making at the small cell meeting for the Hot Topics in Small Cell in New York. And that was on Trop-2 antibody-drug conjugates, which are a novel class of treatments specifically in small cell lung cancer. So she asked that I share that information with this group over here. And I put a little bit of background as I'm going through that that I'd like to go through as well. Here are my disclosures. So regarding antibody-drug conjugates, there's been several different targets that have been looked at in both non-small cell lung cancer and small cell lung cancer. The disease that we're going to focus on today discussing is small cell lung cancer, and specifically the target is going to be Trop-2, although there are other ADCs looking at targets including SEZ6, B7H3, DLL3, and others that we should be aware of. So what are antibody-drug conjugates? So antibody-drug conjugates are really utilizing the power of precision medicine, but at the same time delivering chemotherapy. So that's one component that we need to be aware of when we're giving these treatments. So they have various components. There's the antibody component, which is like a homing device, right? It's searching for a marker on the surface of the cancer cell. And that marker is also known as the antigen or the target. Usually these are present on the surface of the cancer cells. And so that antibody is floating in the body looking for that target or antigen in order to deliver the chemotherapy. The chemotherapy is also called the payload. That's the other name for the chemotherapy. And it's bound to the antibody via a linker. And it is inactive until that linker breaks off and then releases the payload into the cancer cell. That's the ideal kind of situation that we're looking at. Sure. So for these type of treatments to be successful, we want the target to be expressed on the cancer cell with very little expression on our normal cells because we don't want the chemotherapy to enter the normal cells unnecessarily and cause toxicity. We also want to have an antibody that has a high affinity for binding to that target. And we want to have a drug that is active in that type of cancer as well. So these are all things that we have to consider. And then the linkers, they have certain characteristics that I'm going to describe a little bit more on a subsequent slide, but they can be what we call cleavable and non-cleavable. And I'll show you what that means in just a moment. There's another term that's a little that you may hear when you talk about antibody-drug conjugates, and that's the drug-antibody ratio. So in this diagram that I have right in the center, you can see an antibody, and the green circles refer to the chemotherapy drug or the payload or that is tied to that antibody. So the number of molecules of the chemotherapy that are linked to that antibody. Basically, that's the ratio. So a high drug antibody ratio means more drug is linked to that one antibody. And, so a drug which has a drug antibody ratio of 8 means that there's eight of those molecules on average. Something that has a ratio of 3.5, that's the average essentially of how many of those molecules are there. And then I mentioned this term linker that links the antibody to the chemotherapy. And these can either be cleavable or they can be non-cleavable. Cleavable are those ones that are designed to release the payload or the chemo inside the cell. So these ones, basically, they respond to like pH, low pH that can cause them to break down like that. And the thing to know about these type of antibody-drug conjugates that have cleavable linkers, they can cause something called bystander effect. Bystander effect is when that chemo breaks off, it can cross that cell membrane and enter into the adjacent cells. And so the good with that is you can have more cell kill, right? Like if the antibody drug conjugate has hit the target, gone into some cells, adjacent ones that are cancer cells, maybe they don't have the marker on them. But, the cell kill is augmented if the chemotherapy can diffuse across and then kill those adjacent cells as well. And then there are types of linkers called non-cleavable. These ones, they rely on the degradation of the entire antibody drug conjugate by the lysosome enzymes in the cell. And so these type tend to be a little bit more stable in the circulation, and they don't cause bystander effect because they're really affecting those cells that they're going after. So these type of drugs, they're more effective in those situations where you have very high expression of the target, right? But if you have a situation where some expression is there on some cells, some adjacent cells don't have the expression, having a cleavable linker can have some advantages in that regard.
Dr. Waqar, I do have a question. So these antibody drug conjugates, how are they always going to be delivered through intravenously, or is there any time we'll have a pill like non-small cell, like a...
Excellent question. I would say the way they're studied right now, they're IV.
Okay.
But, will there be other delivery mechanisms in the future? Perhaps. The challenge with the pill is, like I mentioned, some of these, they rely on enzymes to cleave, right? So in our digestive tract, we have, chemicals that can cause some of these to break down. So the way they are right now, I would say that these agents in general are IV. And that's the drugs I'm going to be talking about and all are going to be intravenous, and I'll get to that in a moment as well. But I'm just kind of trying to break down each component of this antibody drug conjugate and kind of say the pros and cons. Does this make sense so far?
Yes.
Okay, very good. So a little bit more about the bystander effect. So the antibody, ADC is the acronym for antibody drug conjugate. So this is internalized, and then it's basically degraded. And then the payload or the chemotherapy can also exit into the normal cell. So that can be one way of causing that bystander effect. The second can be if the payload prematurely gets released in the extracellular space. So sometimes in cancers, there's an acidic environment, and that acidic environment can cause some of this to happen ahead of time. So both of these ways can cause some release of that payload, and that causes the bystander effect. Now, I mentioned the word payload or chemotherapy. So there are two main ways these drugs work. Either they affect the DNA of the cancer cell. So there are many types of agents in that respect. You'll hear the word anti-topoisomerase agent. That's one of the type, right? So when the DNA, it's a double helix, it's tightly wound. In order for it to replicate inside the cancer cell and even in normal cells, you need those two to unwind. And then when that happens, that causes some stress, and there can be these supercoils that happen, and that release some of that release of that is through the topoisomerases. So basically, impacting that can cause, an anti-chemotherapy, like a chemotherapeutic effect, essentially. The other ways can be through DNA cleavage. So there are drugs like calicheamycin that can affect that. And then there are drugs that are called microtubule agents. So as the DNA is dividing and getting into two daughter cells and kind of pulling apart, there are these microtubules that pull the DNA into the different corners and kind of help the cell divide into two. So the anti-microtubule agents affect that path over there. But basically, if you think of any payload or any chemotherapy in the antibody drug conjugates that are being used right now, either they're targeting the microtubules or the DNA. So small cell lung cancer, this team, everyone over here is pros. They understand that it accounts for 13.8% of lung cancer, right? Though smoking is the main risk factor for small cell lung cancer, we know that about 2 to 3% of small cell lung cancer can occur in never smokers. We know that there can be transformation to small cell lung cancer when we have non-small cell lung cancer with EGFR mutations or ALK fusions or these oncogene-driven cancers that can then over treatment transform into a more aggressive small cell type. In Asia, actually, the proportion of never smokers that have small cell is even higher than what we see here in the West. And the characteristic gene findings that we see are loss of tumor suppressor genes, TP53 and RB1. This is something we see pretty much across the board in all small cell lung cancers. And, this can be through inactivating mutations. And small cell lung cancers, as you all know, they're characterized by rapid doubling time. These tumors, they like to spread and metastasize very, very early. And unfortunately, most patients present when they already have what we call extensive stage or metastatic disease, right? So if it's confined to the chest, not spread anywhere, there's no pleural effusion. If the radiation oncologist can get it all in a radiation portal, that's limited stage disease. But if it's anything beyond that, that's called extensive stage disease. How we have treated this disease for many, many years has been platinum and etoposide-based chemotherapy. More recently, we've had breakthroughs with immunotherapy entering that space. First, we saw this in extensive stage disease after chemotherapy, and then later on, we got that incorporated into the first line or first treatment that we give to patients. And now, over the past year, we've also had FDA approval of immunotherapy after chemo and radiation. So, that was the Adriatic study. So now I would say in all phases of disease, as long as a patient is a candidate for immunotherapy, meaning there is not a bad autoimmune condition that we think it's not going to be recommended to give, or any other contraindication, we try to give immunotherapy whenever possible. Sometimes lung inflammation or pneumonitis can prevent us from doing that, or interstitial lung disease can prevent us from doing that. So there may be some instances where you may find that the oncologist is not giving immunotherapy, but usually it's with those reasons. The other reason sometimes would be when people have tumors in the brain and they're causing swelling. And so patients will sometimes need to be on steroid therapy to calm that inflammation down. And as you all know, immunotherapy and steroids, it's kind of, they do the opposite thing. Immunotherapy stimulates the immune system. Steroids basically suppress the immune system. So that can be another reason why sometimes there may be some delays in being able to get the immunotherapy. So that's the standard first line treatment that we will give. But when small cell lung cancer relapses, it becomes really chemo resistant. And our group has shown from sampling these recurrent specimens and studying the gene alterations that a pathway called Wnt has been shown to have a role with that. Montessa, I saw you unmute. You had a question, please.
Oh, yeah, somebody in the chat said, what causes lung inflammation?
Excellent question. So sometimes the treatments that we give cause lung inflammation. For instance, I mentioned chemotherapy and radiation. So radiation are high energy beams focusing on the lung mass and the lymph nodes. And as it goes through the lungs, it can sometimes inflame the lungs. Sometimes, rarely, chemotherapy can cause inflammation of the lungs. Sometimes people have pre-existing lung conditions, such as interstitial lung disease that causes scarring of the lungs. So those would all be reasons to kind of think a little bit before giving these type of treatments.
I did have a question. So sort of, I'm trying to think of how I want to word it. I know how, like, when the standard of care is given the etoposide, the carboplatin, and atezolizumab if they're getting the immunotherapy, and that the second line is looked at once there's been like reoccurrence or shown that, I guess, the chemo part of it didn't work. But are there known times when you get chemo, but then you move right into the next phase, even just for more extra treatment? Or does it have to be people wait and to see that, something's come back? My situation with my mom is kind of complicated. And like, I worry a little bit because she finished 3 rounds of the first line just a few weeks ago. And we haven't had a chance to get a PET scan because the doctor wouldn't do it until after 4th round. But she did have a repeat brain MRI after getting targeted radiation back in February. And that showed new growth. And all they were going to do was like, we'll see you in 3 months. So I pivoted quick and I went and I got us to go see Dr. Sands at Dana-Farber next Wednesday to just jump right into maybe tarlatamab, because though we don't know if there was any progression or if it didn't work on their lung, it is moving already forward in her brain. So in your opinion, also, does that seem like the right time to be moving into that next, line of treatment, even though we don't know that it didn't work in her lung because he didn't do a PET scan?
Yeah. So while I can't give a comment regarding a specific patient instance, without kind of looking at everything very closely. In general, just discussing, you asked a very good question. When do we give more treatment? How much is enough treatment, right? So historically, when we've given chemotherapy with a platinum doublet, went from between 4 to 6 rounds. Why did we do that? If we did anything less than 4, we found that the survival endpoints were not as good for people who got less than that. And if we went beyond 6 and we kept going, all the side effects of the chemotherapy were really building up, but the survival was no better, but the toxicities were more. And so folks were not strong enough to get subsequent treatment. So that's kind of how the chemotherapy regimen has been. We've gone between 4 and 6. Now, what you were asking is, do we give more treatments? What we call that is maintenance therapy. Maintenance therapy is when you give something to maintain the cancer where it is, right? Because with the chemotherapy, usually the first few rounds, we see good shrinkage, give a little bit more, and then the shrinkage kind of like, it becomes a little less prominent. At some point, we see stability. Sometimes we get lucky and we see no evidence of disease on the imaging, basically what we call a complete response, meaning the cancer's disappeared. But if we keep going with more chemotherapy, usually you don't have any more augmented response. Immunotherapies, as I mentioned, initially were in the second. So the idea was, can we bring some of these treatments earlier on as a maintenance? And some of the key things that we look for a maintenance therapy are, we want to give something that has less side effects. We want to give something that a person can take for a long period of time without feeling bad, and something that we think is going to improve their outcome as well. And immunotherapies checked off many of those boxes. We all know that immunotherapy is not completely side effect free, right? If the immunotherapy stimulates the immune system too much and it gets too heightened, what can happen is sometimes it can attack the body, right? The other thing to note is, and you brought this issue up, that small cell lung cancer likes to spread to the brain. Many of the treatments that we have don't penetrate very well into the brain. And so when we give treatments for small cell lung cancer, we like to monitor not just the disease in the body, but also the status of the disease in the brain so that we can tailor our treatments based off of what's going on, right? Now, immunotherapies, they can have some impact with tumors in the brain. I have a patient where she had no disease, and so she had a metastasis at the beginning in the brain, but had no radiation to that, and the lesions disappeared, and she had a complete response with chemotherapy and immunotherapy. Finished 2 years of immunotherapy, and has just been in follow-up. Now, is that every single person who has small cell lung cancer? I wish it was, but unfortunately, that's not the reality, right? So everyone's different, and sometimes with immunotherapy alone, we can see an impact in the brain. But when tumors are larger, when they're causing swelling, then immunotherapy is not sufficient and can actually sometimes cause those lesions to swell a little bit more. And that's why in the clinical trials of tarlatamab and other agents, patients who had large brain tumors that were untreated for safety reasons were not allowed to go on to the study without getting them treated first. Now, having said that, are there instances with small brain tumors that we are in the real world setting seeing people get tarlatamab? Yes. But that's why, Robin, I wanted to say, I think we really have to look at the full context of what's going on before rendering an opinion. And I think seeing Dr. Sands is a great idea. Okay.
Thank you. Yeah, and you've elicited more questions. So you have about 3 questions in the chat. The first one is about the lung inflammation. Is the lung inflammation short-term, or could it last for quite some time?
Yes. So the inflammation generally kind of from radiation or drugs or anything, it starts, it peaks, and then usually it calms down and settles down. Now, it can have some long-term consequences. It can sometimes cause scarring as well. So the goal of treating that inflammation is making the severity less. So, sometimes people have a little bit of low-grade inflammation and it's not really causing them any symptoms, but we just see it on a scan. That is less worrisome than having shortness of breath and needing oxygen with it, right? But still, it's something that needs to be monitored, right? If we see inflammation on the lungs. If we institute treatment for that, if a person's having symptoms, we want to get on it quickly, right? And lung cancer is tricky because shortness of breath, that's such a common symptom with someone going through treatment for lung cancer. It can be from their cancer. It can be from treatments like, inflammation we just talked about. They could have a pneumonia, right? It could be as a result of a blood clot, pulmonary embolism. There's so many different things that can cause shortness of breath. And so, the key is being in communication with the provider, with the doctor, the nurse practitioner treating the patient, letting them see what the severity is, coming in for assessment, seeing does a scan need to be done, does any other further evaluation need to be done. And if you get on the inflammation early, usually you can get it under control. But sometimes, even despite that, there can be some sequelae or some complications where there's some scarring left behind. So, it depends on the severity of how bad the symptoms were. It also depends on when the inflammation got under control with the treatment.
Okay.
But the hope is to prevent those long-term complications and consequences.
Okay. Thank you. And oh, sorry. Does the pneumonitis cause scarring in the lungs?
That's exactly what I was just saying, that the pneumonitis, pneum means lung, pneumonitis means inflammation of the lung. So the inflammation of the lung can cause scarring. And so the goal of treatment is to calm that process down and to prevent that from happening. Okay, but sometimes there is some scarring that can still develop.
Oh, and so I think Donna had one follow-up question to your statement. If you said if your NED, as I think you said was cured, would you need any more follow-up treatment or wait and see if it comes back? Or do you need to, or NED/cured, we need immunotherapy?
So you're asking about the patient case that I discussed? Is that what I'm understanding?
Oh, Donna, please unmute and you could clarify if you would like.
Yeah, what I'm asking is, like, say you are limited stage and after your treatment there's no sign of the disease, it hasn't spread, and would you do immunotherapy then, or would you wait till disease shows up in a CAT scan or a PET scan?
I see. So Donna, for limited stage disease, the standard now, and I have that on this next slide that I'm showing, based on the Adriatic study, after chemo and radiation is completed, we get scans, make sure the cancer has not spread anywhere, and that's the time that we give the immunotherapy. And that immunotherapy is to help decrease the odds of it spreading to the brain, help to improve the odds of a person being cured of their cancer.
Okay, so now it's been like over a year since I've been treated. Would I still benefit from doing immunotherapy?
So this study was done where patients within 42 days of finishing the chemo and the radiation were put onto the immunotherapy. So if it's been years since a person's, finished their chemo and radiation, they would be followed with what we call surveillance scans, where there's scans of the body, scans of the brain. And as long as there's no recurrence of cancer, that's what we would continue to do. If the cancer were to recur, because it's been so long, then one of the possibilities could be giving chemotherapy with immunotherapy again, or it could be, other treatment options as well. And so this timeline I have here just kind of summarizes those treatments I was discussing a little bit. And I think this might be helpful because it shows the pace of the progress. And you can see that this starts, 1985, first line platinum and etoposide induction being given. Limited stage.
I'm sorry, it's so small I can't even see it. I can't. Yeah.
I'm so sorry that it is so small. So basically, in yellow is chemotherapy, in blue is an immunotherapy, and then the orange is basically chemotherapy with immunotherapy. So the points I want you guys to take home over here, that in the 1980s we started using platinum and etoposide. Right now we're in 2025, right? So in this time frame, in this period of time, what has been going on, right? 40-year period of time. So, we had more chemotherapy regimens, topotecan, basically instead of cis, we started using carboplatin as well. This is really the pace for the past, I would say up till 2012. 2018 is where it starts getting exciting, right? We have accelerated approvals for immunotherapy with first nivolumab and pembrolizumab, and this was for people who had received chemotherapy already and the cancer had progressed. And then we started seeing these drugs move to the first line setting. And so we have two approvals, atezolizumab and durvalumab, which are anti-PD-L1 drugs in combination with platinum-based chemotherapy. Those were approved in 2019 and 2020. There is a chemotherapy drug, lurbinectedin, which was accelerated approved in 2020. And then tarlatamab, I heard many of you are very familiar with that agent. That was approved last year. And then the Adriatic regimen, which moved the immunotherapy not just to extensive stage, but also to limited stage patients. So basically, more patients have access to immunotherapy. So these are just the FDA-approved treatments. And I wanted to kind of show that before I move forward to what we're talking about today. And I'll pause right there. I'm sure there are questions.
Nope, I actually don't have any in the chat right now, but
Okay, very good. So, in the NCCN guidelines, these are really the preferred regimens that we have for relapsed small cell lung cancer. And you can see that from the numbers of response rate, they're not that great, right? We really want great treatments for our patients with lung cancer. But for chemotherapy, especially for relapsed small cell lung cancer, and the CFI is chemotherapy-free interval. So if the chemotherapy-free interval is greater than 90 days, meaning you finished platinum doublet and it's been over 3 months or 90 days and the cancer grows after that. If you were to give chemotherapy, there's more likelihood that the chemotherapy is going to work. But if the cancer progresses quickly during chemo or in that shorter time frame within the 90 days, you can see that chemotherapy does not work that great. And that's in the bold. That's really summarized there. In red, what I have boxed are two drugs, topotecan and irinotecan. And the reason I have them in a box are these are topoisomerase 1 inhibitors. Why does this matter? Because many of the ADCs we're going to talk about are topoisomerase 1 inhibitors. So will those type of drugs work, if you've already had a drug previously that goes after that mechanism of action? That's something to consider, right? And then the exciting drug this year has been tarlatamab, which is a bispecific T-cell engager therapy, which is a molecule which in one hand takes the cancer cell, the other the immune cells, and brings them essentially together so that the immune system can attack the cancer. And these treatments, are active in patients where the cancer grows quickly after receiving chemotherapy and also active after receiving, chemotherapy if the cancer is growing months later. So in all patients, about 40% of them will have a tumor response. So Trop-2 stands for trophoblast cell surface antigen, and it's a transmembrane glycoprotein. So basically, it's on the cell membrane, and it's encoded by a gene that's called tumor-associated calcium signal transducer 2, or TASC, or let me just say TACSTD2. That's the kind of acronym for the gene, okay? But basically, for short, a lot of people just call it the Trop-2 gene as well because it's easier to say. So when we talk about lung cancer and Trop-2 expression, older studies have shown that, in adenocarcinoma, which is a type of non-small cell, and squamous cell carcinoma, another type of non-small cell lung cancer, the expression of Trop-2 is quite high. But for high-grade neuroendocrine tumors, so neuroendocrine tumors within that small cell is a subtype of that, it's much less. It's 9.5%. But I wanted to also draw your attention to the way you test matters. So these are immunohistochemical tests. So what they do is they put some stains, and then they look under the microscope and they look at the intensity of the staining, and they also look at the percentage of the cells that are staining, the cancer cells that are staining. And so using the criteria listed here, those levels are low, but every study and every drug has used a little bit different testing platforms and criteria of what they call positive. So you'll see that in some studies, this number will be a lot higher than this 9%, as I'm going to show in subsequent slides. The other thing to note is that the Trop-2 gene expression levels. So expression levels is basically the gene making RNA and then making protein. So the expression of that is lower in the lymph nodes and in distant metastasis, like in brain metastasis, when we compare to primary lung tumor. So the cancer spreads from the lung to the lymph nodes and the brain, and you see more of the protein in the primary tumor than you do if you look at corresponding lymph nodes and corresponding brain metastases as well, okay? Why does this matter? This may matter when we're looking at treatments. Somebody who has a brain metastasis, then is this the way we want to be treating, with a drug like this, or should there be a different strategy? The other thing to note is when we look at relapse specimens. So by relapse specimens, I mean when a person has small cell. There's been a lot of studies that have been done looking at the sample at presentation. And historically for cancers, a lot of treatment decisions have been done based off of what was there at presentation, right? But the cancer morphs over time. It becomes aggressive. So we need to figure out what are the mechanisms of resistance, what's going on, and we want to pivot and be ahead of what's happening with the cancer. And when we've looked at samples at relapse, we've seen that the expression of the Trop-2, it's less than compared to the primary tumors when at the time of the diagnosis. So that's another thing to factor in. Why that matters is as we look through development of these agents, perhaps we should be using them earlier rather than as the 10th treatment that we're going to give to a patient. So heavily pretreated patients may not have the same responses to these type of treatments given these findings. That's something I wanted to highlight and show. So I know this looks complicated, but I just wanted to kind of summarize that and explain that to the best of my ability here. Does that make sense?
Yes, so some of these studies are going to be targeting limited stage or
no, right now we're not talking about limited stage. We're talking about relapse small cell lung cancers.
okay.
Drugs are right now being developed in patients who have relapse small cell, meaning that the cancer has come back, right? That could be after being treated for limited stage. That could be after being treated for extensive stage. Okay?
Yep.
Okay.
Or relapse with second biopsy, what is standard staining?
Yeah, so what I'm saying is that if we look at paired tumor samples, right? So this one over here, the one that's in the extreme right, when we looked at paired tumor samples, meaning the same patient at diagnosis, the same patient when the cancer relapsed, we're seeing that the expression is less in the relapse samples compared to the primary. The one that's right before that is showing grouped data, meaning a group of patients where the tumors were at diagnosis and a group of patients at relapse. So it might not necessarily be the same individual patient's paired samples. But on the far right, you see the paired samples are showing the same thing. So this is data done preclinical studies in the lab. Okay. So then moving on to the first antibody-drug conjugate that we're going to talk about. So I'm sorry, it's 6:40 and we're just getting to the meat of things now. So I hope I'm not keeping you guys too late over here, but please let me know if we need to, if anyone needs to leave or we need to regroup later. So the first one is sacituzumab govitecan, which you can all see is a mouthful. So for short, we call it SG, okay? So SG is an antibody-drug conjugate, which targets Trop-2. It has a high drug-to-antibody ratio, 7.6:1, meaning one antibody will have that many payloads or chemotherapy molecules on it. And the antibody is a humanized anti-Trop-2 antibody. So the humanized antibodies are less likely to have us react against them compared to if they're mouse antibodies or other antibodies. And then the chemotherapy is SN38. SN38 is a metabolite of irinotecan, which is a chemotherapy regimen that's used in small cell lung cancer, but it is much, much, much stronger in terms of the potency, like 100 to 1,000-fold stronger than irinotecan in terms of the potency. So the first in human study, so first in human refers to when the drug is first tested in patients, right? So the first in human study that was done of this agent, which included patients who had small cell lung cancer, 91% of the samples that were available for testing for Trop-2 were testing positive for Trop-2. So you're going to say, wait a second, Dr. Waqar, you were telling us earlier that the frequency is less. This is what I'm trying to tell, that it depends on how you assay the marker. So the assay that they used, they said 10% expression, and then they looked at the intensity. If it was weak, it was 1+. If it was moderate, it was 2+. It was 3+. If it was strong. But it was 91% of them actually had some Trop-2 expression. And when they looked at the extent of expression and how high that expression was, there was not a correlation with outcome. So basically, people who had their tumor stain very highly for this didn't have a better outcome with this compared to the ones that did not have high expression. So the study that was presented at the World Lung Cancer Conference, and now this is published, is the TROPICS-03. This is a phase 2 study, which was a single-arm study. So this is not patients randomized to this versus another drug. This was all patients who had extensive stage small cell. They had disease progression after platinum and immunotherapy, essentially. And they have to have something called measurable disease. So what does that mean? What that means is, in clinical trials, when we look at a lung mass or a lung nodule, it has to be a centimeter or more in size. When we look at a lymph node, the lymph nodes are not circles, they're ovals, right? So we're not looking at the long portion, we're looking at the short portion of that. And that has to be more than 1.5 centimeters, right? So pleural effusions or fluid outside the lungs, that's not measurable disease, right? It's cancer, but it's not measurable disease. If there's a liver spot, it has to be 1 centimeter or more. So that's kind of how we talk about measurable disease. So they had to have something that they could measure using the criteria we use for clinical trials called the RECIST criteria. They had to be strong and robust. You are all, I'm sure, familiar with ECOG performance status and the limitations of performance status. The reasons that they limited it to ECOG PS 0 to 1 is it's a new drug and they're examining the efficacy of it, and they don't want patients who are very frail to undergo a treatment that could cause a lot of toxicities. And they want to ensure that the patients that they're giving the treatment to, they can actually assess and see how they're doing. Now, they did allow patients who had brain metastases, but they had to be treated and they had to be stable, okay? And they could only have had one platinum and immunotherapy. They couldn't have had any more treatment. So they couldn't have had topotecan, they couldn't have had irinotecan. So that means that they were not given a prior topoisomerase 1 inhibitor. Okay, and there were 43 patients who had extensive stage small cell. They got this medication intravenously. It is weight-based dosing as it was delivered. It is given on days 1 and 8 of a 21-day cycle. So if you come in on one day, get treatment, a week later, get treatment, then a week off. 2 weeks on, 1 week off, essentially, is how it's given. How long was it continued? As long as the cancer did not progress or there wasn't a bad side effect that it was felt that this should be stopped. And they were followed for survival and outcomes and toxicities and how they were doing. The primary endpoint of the study was to look at response rate. Secondary endpoints were the duration of response, clinical benefit rate, progression-free survival, and then they also were looking at overall survival and safety. So the median age of the patients enrolled to the clinical trial was 67 years, which you all know is younger than the median age for lung cancer, right, which is 70 years, so younger patient population. About 46%, 46.5% were male, right? So there was a representation of men and women in this study. As far as the race goes, most of them were white, but it did include other races as well. Current or former smokers, most of them were former smokers or current smokers, about 97%, which is consistent with what we see with the demographics here in the US. And as far as the performance status, the ECOG performance status was mostly ECOG PS1 for the patients, with a smaller proportion having ECOG PS 0. This study included patients who had both platinum-resistant and platinum-sensitive disease. So again, how this is defined is if it's been like 90 days since they got chemotherapy, we're not talking about the immunotherapy component, but chemotherapy, that is platinum resistant if the cancer has progressed. If it's after 90 days, it's considered to be platinum sensitive. And most of the patients had stage 4 disease when they presented. There would have been some patients who had limited stage disease, got chemo and immunotherapy, and then had progressed. And then for metastatic disease sites, you can see that the liver metastases that were very common, 30% of them had that, 11% had brain metastases. All of the patients had to have platinum and they had to have immunotherapy. That was the inclusion criteria for the study. And with their prior treatment, with the chemotherapy, the best response was either a complete response, meaning they couldn't see any evidence of the disease, or partial response, meaning that there was some disease, but it was shrunk down 30% or more from where they started in about 55% of patients. And then the rest, they had stable disease or they had progressive disease. So it shows a good representation of all. It's not just the patients that had the best outcomes with the prior treatment that were included in this clinical trial. So here is what we call a waterfall plot. So on the left side of the slide, this is the waterfall plot. So you can see that the bar over here, this is 0. And if the cancer burden is decreasing from baseline, the bars are pointing down. If the cancer burden is increasing after baseline, the bars are pointing up. That's how we commonly will show the responses, okay? And when we look at the 30% mark, this is where we look to see that anything that's below this, these are the patients that we say have a response. These patients still had some benefit. They had the tumors decrease, but it did not constitute the 30%, which you can argue is an arbitrary cutoff number, right? So that's why I'm showing this, that most patients actually derived a benefit from this treatment. And even the patients where the tumor had increased somewhat, you can see that most of them still had it below the 20% cutoff. Now you'll see that there's orange bars here. So these patients here in orange, they had progressive disease, although the percentage was not greater than 20. What this means is they likely had new sites of cancer. So right now in this waterfall plot, we're measuring what we had at the beginning, at the start, and where we are, you know, as the best response. But if there are new sites of disease, that's not being captured in this waterfall plot. And that's why these orange bars represent those patients. Does that make sense? Okay. Then right next to that is the spider plot. So this shows basically the duration and how some patients are in the green that you can see are continuing on for treatment for quite some time. Whereas the ones that progressed, you can see over here, they progressed pretty quick, right? So basically their progression of disease was early on. But if you have a patient who gets through and is doing fine with treatment and they're responding, it seems that those responses, they can stay for a while over here, which is encouraging to see. Now here is the data broken up over here by platinum resistant and platinum sensitive, okay? So you can see that the response rate is reasonable looking at what we're seeing historically, right? So for patients who have platinum-resistant disease, I had mentioned to you the response rates are like 9 to 20%. They're pretty low. So to see a 35% response rate is a number that we like to see, right? But this is a small sample size, right? It's 43 patients that we're looking at, but it is indeed encouraging and something that warrants looking at further. And for platinum-sensitive disease, that response rate was even higher. It was 47.8%. And you can see all the other numbers mentioned over here. One statistic I'd like to point out over here is what we call the disease control rate. So this is the responses plus stable disease. So, you know, these are patients who are having some benefit from the treatment, and those numbers look good, 70% even for patients who are platinum resistant. And for platinum sensitive, 95.7% are having some benefit from this treatment. So that's really good. Here are the Kaplan-Meier plots of progression-free survival. So at the beginning, everyone's alive. Unfortunately, as time goes by, we start seeing some patients whose cancer progresses. Progression-free survival captures the effect of this specific treatment, but overall survival looks overall, including other treatments, the effects of other treatments and subsequent therapies. And so I'm showing both plots over here. And the question that I had was, what are the side effects of this treatment, right? So the side effects, the most common one is diarrhea. And irinotecan, which is the parent drug, also causes diarrhea. And the other thing that's pretty common with this is, having blood counts that are low. Fatigue is something we can see. And fatigue, we have to really appreciate the impact that can have on patients. Because if you're so tired and exhausted that you can't do much, okay, even if you're not having nausea and vomiting, that's really a detriment to quality of life. So it's something we really, really need to factor in. And diarrhea, diarrhea can be debilitating. When we look at grades of toxicity, we use these criteria called CTCAE criteria, and they look at the severity in terms of whether, how many bowel movements, if it's causing incontinence, if it's affecting the activities of daily living and self-care and all of that. But having, grade 2 diarrhea even is bad. Even grade 1 diarrhea can limit what a person can do. And then this agent can cause thinning of the hair. So alopecia is listed as one of the toxicities, and it can cause nausea. Electrolytes need to be looked at. Magnesium levels can be low. It can cause skin rash, but that's not very common. I mentioned the low blood counts already. When we look at any grade side effects, basically everybody had some side effect with this treatment. When we look at more than grade 3, which is, the grades go from 1 all the way, to 4, and 5 is if unfortunately we see a death, which we never want to see with a treatment. So grade 3 or higher side effects we saw in about 3/4 of patients, which is still something that is a significant toxicity. And then, we can dose reduce. If we see that there is a side effect, we can reduce the dose. None of the patients discontinued the treatment because of the side effects, but there were 3 deaths that were on treatment. And one of the deaths was unrelated to treatment. That was because of pneumonia. One of the deaths was from neutropenic sepsis, which means that the blood counts went low, and that was related to treatment because the chemotherapy caused the counts to be low. And the third was sepsis, which was felt to be unrelated to the study therapy. So what's next as a result of this? So we're awaiting the biomarker analysis, because what I showed you earlier on was the first in human study. We really haven't seen the biomarker analysis of this study with the Trop-2 expression. The FDA granted breakthrough therapy designation for this treatment as a second line in December. Of course, this is not FDA approved yet, and we're still looking at confirmatory studies. There is a phase 3 study called the EVOKE Small Cell 04 study, which is being launched looking at second line setting. This drug versus the standard of care. So they're trying to see what the place of SG is going to be. There's also been an example looking at a phase 2 study using this agent earlier on as a maintenance. So I think it was Robin who had mentioned, how do we bring these treatments earlier on? So looking at giving chemotherapy and immunotherapy followed by maintenance immunotherapy in combination with SG. That's a study which is ongoing. I don't have any data or anything for this, but these are ongoing analyses. So the second agent now, SHRA1921. Oh my gosh, that's a mouthful, right? So it's just letters and numbers so far. So this is another antibody-drug conjugate that we have seen some data presented at the World Lung Cancer Conference. And this is also a topoisomerase 1 inhibitor payload, also targeting Trop-2, also with a cleavable linker. And this was the design of the clinical trial. So this was patients who actually had extensive stage small cell. They excluded people who had mixed tumors. So sometimes we see where there's non-small cell and small cell together in the same sample. Those patients were actually excluded because they really wanted to look at extensive stage small cell. Now, they mandated that the patient should have had platinum-based chemotherapy. And they allowed immunotherapy, but they did not mandate immunotherapy. So you can see this is very different from the clinical trial I showed you previously, right? They allow more lines of treatment with this one. Immunotherapy is allowed, but it wasn't mandated for everybody, so it's not that same uniform population. This study was done in Asia, where, how we give carboplatin etoposide for our patients first line. They did clinical trials where they found that irinotecan instead of etoposide, that's often a first line regimen that's given there as well. So, and they did allow irinotecan as a topoisomerase inhibitor to be given before they went on to this study. So that's interesting to know and different and discrete from the previous study. Again, patients had to have measurable disease, the same ECOG performance status criteria of 0 to 1, and they needed to have a tissue sample that they could use for testing for Trop-2 expression. This drug is also intravenous, but it's only given once every 3 weeks, unlike the previous drug that was 2 weeks on, 1 week off, right? Still 3-week cycles. Again, treatment was continued until disease progression, unless there was a toxicity, or if the patient chose to withdraw, or if the investigator thought it was in their best interest to come off of treatment. Now, again, this is even younger than the previous patient population that we were looking at. So 17 patients. So this is a phase 1 study. So looking at safety, right? So they have some preliminary efficacy we'll look at as well, but only 17 patients, and they're pretty young. 60 years is the median age. Most of these were male. Again, the previous study I showed you, you saw a little bit more women. This is more males in this study. And then for the ECOG performance status, you can see most of them were PS1, just like the previous study. Most of the patients were either former smokers or current smokers, but look at the never smoker population. Even though it was 4 patients out of 17, that's 23%. So this is what I was highlighting earlier when I said in Asia, we see more never smokers who have small cell compared to here. What are the reasons? Pollution or other things? It's hard to know, but there definitely are differences. And then as far as previous treatments, in the previous study, I showed that everybody had had one treatment only. Here, 47% had had one prior treatment, but over 3 treatments were seen in about 30% of patients. So these are much, much more heavily pretreated patients in this study. And about 11.8% have had prior topoisomerase inhibitors, right? And then everyone has had platinum-based chemotherapy. With immunotherapy, only 64% had had that. There was prior radiotherapy delivered. Why is this important? Because some of the toxicities of ADCs can include lung inflammation or pneumonitis. So they included this data as a background for us. And then as far as Trop-2 expression, you can see that most of the samples were negative. Look over here at the bottom that the negative were 88.2%. NE is not evaluable, meaning they couldn't run the test. And then low expression was in about 5.9%. So these data are very different from what I was telling you. But again, this assay is different. And how they qualified this is an H score, which is a numerical score, which is a complex formula, which is at the bottom, which it looks at 3 times the percentage of cells with strong intensity plus 2 times the percentage of cells with moderate plus 1 times the cells with mild intensity. So they add all of those numbers to come up with that H score. Here is the waterfall plot where you can see the responses, and about a third of patients had a response with this agent. The disease control rate was 66.7%. And you can see some preliminary data looking at the time from first dose, where you can see that there's a patient who's ongoing on treatment after 39 weeks as well. Here is the preliminary progression-free survival data. So median progression-free survival was 3.8, but as of the cutoff date, the median overall survival had not been reached. Toxicity-wise, so you can see the toxicities are a little different from what we were seeing previously with the previous agent. So common toxicities with this include stomatitis or sores in the mouth, nausea, vomiting, decreased appetite, liver enzyme elevations, anemia, weight being decreased, which could in fact be a result of the stomatitis and nausea, because if you can't eat because your mouth hurts or you're nauseated, your weight's going to go down, right? That's what happens. And then there's some unique things that are a little bit different from what we saw. Hypertriglyceridemia, amylase elevation, ALT increase. So the amylase and lipase are enzymes that sometimes go with pancreatic inflammation. And so those numbers were numerically higher. ALT is a liver enzyme that was increased. We also looked at blood counts in this one. Neutrophil count was decreased. The albumin level dropped, which could also be a function of the nutrition, but could also be a function of the liver not working as good, which makes the albumin. And then there was a skin rash associated with this as well as low blood counts. Any grade, everybody had some sort of toxicity. Any grade meaning mild or severe. But grade 3 or 4 were seen in about a third of patients. And the toxicities leading to treatment discontinuation, none of the patients. And this really shows that patients with small cell lung cancer, they put so much effort and so much time, and they really want to see a treatment through. They want to continue trying a treatment because they want every option they can, that could possibly help them. They're just so motivated. But treatment interruptions and dose reductions were needed for some of these toxicities. And none of the toxicities led to death in this study, which was fortunate.
I know
So
you had, I'm sorry, you talked about mouth sores. Somebody in the chat said no changes in taste with any of the Trop-2 studies.
yeah, so the excellent question that was asked. So changes in taste are often seen in patients who have who get chemotherapy. Another Trop-2 antibody drug conjugate, Dato-DXd, that has been studied much more in lung cancer and is approved in breast cancer. That one, in addition to stomatitis or mouth sores, can also cause some altered taste as well. These data are basically what we have. So this is what's been presented. There's no other data that's published. So if the taste sensation was altered, the frequency did not make it to this chart. That's all I can say. But I would absolutely not be surprised if there were patients with any of these drugs that had altered taste changes. Okay. And then the future directions of this agent. So the phase 1 study, so as I mentioned, it was presented at the World Lung Cancer Conference. Looking at clinicaltrials.gov, the status of this is unknown. The estimated primary completion date was August of last year. So I'm hoping that we'll have additional data in subsequent conferences that we'll be seeing. There's a combination study that's ongoing in China, which is not yet enrolling patients that will hopefully be enrolling soon. And then, one thing I pointed out over here, there's a study looking at patients with breast cancer, where they were looking at this agent in combination with bevacizumab, which is a drug that is often given when there is tumor in the brain and there is radiation necrosis associated with this. This medicine can help a little bit with that swelling, helping people get off of steroids, and also has some anti-cancer effect in some tumor types. So it was interesting to me that it's being examined, which makes me wonder and think perhaps there is some intracranial activity associated with this. But we don't know. And I did show you preclinical data earlier on that the expression in brain tumors compared to primary tumors is less. And then there are other combination studies going on in non-small cell and ovarian cancer, but there really are no small cell studies that have been opened yet. I don't know if it is just that it's too early in the study. Like I showed you, this is the phase 1 clinical trial data, and that's why, but this is what we know so far about this. So let's compare the two studies a little bit in the two drugs. So both of them have antibodies against Trop-2. Both of them have cleavable linkers. Both of them cause bystander effect. Both of them have topoisomerase 1 inhibitor payloads. The drug antibody ratios are a little bit different. It's higher for sacituzumab govitecan or SG compared to the SHR drug. Here are a comparison of the data we just looked at. So the SG study was a phase 2. SHR, this is much earlier on in development. It's just a phase 1. All patients for SG got immunotherapy. About 2/3 did for SHR. Treated brain metastases were allowed in similar percentages, but no prior topoisomerase 1 inhibitors were allowed for SG, though they were allowed in about 11.8% patients actually had them for SHR. And they were heavily pretreated patients in the SHR study. So the response rate for the efficacy, we see it's lower for the SHR. Is that a function of the fact that we are looking at heavily pretreated patients? Perhaps they have less expression of the Trop-2. That's possible. Is it a drug issue? Is it that the first drug SG is more active? We don't know, right? Because they work differently. They're different drugs, even though the mechanism of action is same. And you saw the toxicity profiles were quite different for both of them. What's interesting is for SG, we saw that there was a response of 35% in platinum refractory or platinum resistant patients. They did not specifically provide those data for SHR, so we don't really know about whether there are responses in that patient population or not. But these are not the only Trop-2 ADCs. I mentioned Dato-DXd, which is also got a topoisomerase 1 inhibitor payload. There's another drug, SKB264, which is a topoisomerase 1 inhibitor as well. BLM02D1, again, topoisomerase 1 inhibitor payload. And then LCB84, which is got an MMAE or microtubule inhibitor payload. So the microtubule inhibitor payloads with MMAE tend to cause more neuropathy, peripheral neuropathy associated with them. So that's a little bit different from the others. And so most of these are either phase 1 studies or phase 1, phase 2 studies, not particularly just for patients with small cell lung cancer, but including include multiple solid tumors, which include small cell lung cancer. And you can see the clinicaltrial.gov numbers, as well as the study start dates and the status. So we'll stay tuned to see those data when they become available. So to summarize, both of these agents show some promising activity in previously treated small cell lung cancer, but have different toxicity profiles. And the optimal sequencing, we talked about tarlatamab, and the post-tarlatamab world becomes undefined because these studies, they were conducted before tarlatamab was a standard treatment, right? So how that fits into the tarlatamab space, we don't really quite know. And then perhaps using these agents a little earlier in the course of disease rather than giving it as the 7th, 8th, 9th treatment would make sense. And that's all I had to share, but sorry to go a little bit over the time.